we have resolved. And Saurabh, you can please start your presentation.
Okay, sir.
Invisible dermatosis. What I just a moment, Saurabh. What I will do
Yeah.
just a moment.
Okay.
I'll for a moment I'll mute you and then unmute you. Then you unmute yourself. I'm making you a
Okay.
co-host. And do you want to make Saurabh Singh co-host? Yes. And now I'm muting everyone. So you now unmute yourself so that till your this thing.
Sir, I am unmuted only, sir. I think.
No. Right now you are unmuted, but
Okay.
now everyone will be muted.
Okay.
So now you unmute. Saurabh, you unmute yourself. Huh?
Okay, sir.
Yes. And
Yeah, I have to share
share
my
your
screen. Yeah.
screen. Share your screen, please. Very nice. Thank you. Now
Thank you, sir.
nobody else will be able to unmute till the end.
Okay.
Right.
Okay. Okay. Thank you, sir. So here I can start. It is a challenge to pick up topics which are actually not well covered in literature, and some of our experience adds to it. We have been surprised in our daily practice and in teaching also by several interesting cases. So I have basically, in a way, this is a huge topic if I keep presenting, but I have tried to introduce what is the concept behind it, what is the ideology with which I am presenting this, and then some of the cases, the theory, and then we'll get back to our practical cases that we saw in our OPDs. So I have basically used these two terms interchangeably, invisible or subtle dermatosis. So this is primarily a histopathological approach. We have some dermatoses which are clinically invisible and some are which are histologically invisible. So more so emphasis will be on dermatoses which are histologically not very definable, do not have a very classic histopathology picture. So most of the images other than our patients are from literature, and patient images of course are my own. So this is what the flow will be like. Initially I will tell you what the concept is, then some of the examples, a few cases of our own, and then we close up. So invisible dermatosis is a terminology which has been in use, which has been in vogue for some time now, right from days of Dr. Kligman. And since the 1980s and 70s, this has been used. Initially, it was primarily used for entities when we do biopsies. We see a skin lesion when we do a histopathology biopsy. We order that and we come to notice that we don't have specific histopathology findings and we are unable to reach a final diagnosis. So those were the cases where the histology was not able to contribute. So primarily, those were labeled as invisible pathologically. But then some authors like Dr. Kligman brought in like terminology of dermatosis which are invisible clinically. And subsequently, there have been literature, one report from one review article from India also, and they have debated this issue. And more or less now it is thought that okay, we can use the term for both, whether histology is uncertain and invisible, or clinically it is not very definite, and we are unable to reach a diagnosis. So this is my way of thought. This is my concoction. It's not very different from literature. Just nitpicking, and we come to something else. So I think more so, what I have tried to focus in this talk is regarding subtle dermatosis. So whereas we see lesions which have distinctive clinical appearance, then but we are unable to see very uh, differentiating histopathology findings. So those we can use the term subtle. Then we have truly invisible when you have clinically inapparent lesions. So I have not really touched upon this topic because if the lesion is clinically very inapparent, then why would we go for histopathology? Why would we biopsy the lesion? So this is something which is truly invisible, and maybe once in a while we see such cases, but more often than not, when you do clinical pathologic correlation, we are often faced with surprises. What we thought on histopathology and what we saw clinically do not match. So some of those things can also be covered. I can tell you some of the finer points in histopathology by which we can reach a diagnosis. So, moreover, we have to recognize the patterns. It is of paramount importance, as we all know, pattern recognition. So, first of all, we should start seeing our slides at low power, or what is commonly called as scanner view, and we should scan it from top to bottom. So, it's a mixture of the algorithm theoretically that we use, the pattern of inflammation, and the tissue reaction. So, these are some of the series of cases taken from theory, about which I'll tell you some of the soft pointers. So it's like picking up breadcrumbs. So I have broadly divided them into predominantly epidermal and predominantly dermal. So starting from disorders like ichthyosis, in which you have clinical involvement, which is quite apparent. You have scaling, you have sometimes fissuring also. Scales can be of so many types. They can be brown or light colored, and so many patterns are there. But as soon as you do histology, as soon as you do skin biopsy, you won't see much. So ichthyosis is one of those conditions wherein I would say histopathology is not recommended, barring one or two differentials. Like you have epidermolytic ichthyosis, wherein you will see epidermolysis or vacuolization of the keratinocytes. And some soft pointers may be found in ichthyosis vulgaris. So in ichthyosis vulgaris, you have absent or hypogranulosis. Granular layer may be absent. So it is one of the differentials sometimes for psoriasis, because in psoriasis also you can see loss of granular layer, but there are so many other findings in psoriasis that it's not really confused with ichthyosis vulgaris. And then there are certain other disorders like rarer disorders like Chenerin-Dorfman or Refsum's disease, where you can see lipid droplets in the basal layer or the spinous layer. So these are some of the rare disorders.
Saurabh, your voice is little bit less. So can you please speak little
Okay,
louder or come near the mic?
okay, sir. Is it clear now, sir?
Better than before.
Okay. Uh, okay, sir. Yeah. And then the other group of disorders is porokeratosis. In this also we see clinically very well defined thin wiry edge lesions and plaques. But sometimes in histopathology we are unable to see coronoid lamella. We run after the life of pathologists, our dear friends, that we are not able to see coronoid lamella. How do we label it as porokeratosis? And they are in fact in reverse out of their mind, and they are after our lives. So oftentimes it happens that coronoid lamella is not seen, and it is often seen after subsequent sections or multiple step sections. What you may end up seeing initially on the first slide itself may be just some papillary dermal lichenoid infiltrate, some lymphocytic infiltrate which is attacking the basal layer. That's it. So somehow some people may think of it as a lichen planus slide. But if you do subsequent sections, and there has been literature also on this, especially a series by Dr. Rajiv Joshi, they had clearly pointed out that sometimes you eventually see is just lichenoid infiltrate. And after that, if you have high index of suspicion, then you keep on doing step sections, and then you will be able to find that coronoid lamella, which was just not visible in the first slide. So deeper sections are a must. And this is just a quiz slide. I understand that none of you can answer, but okay. What you are able to see here is hyperkeratosis and mild acanthosis. And in the left side lower photograph, you are seeing some amount of parakeratosis and a follicular plug. So parakeratotic shoulder is there. And in the right side bottom image, what you are able to see is alternating parakeratosis. So when parakeratosis and orthokeratosis, that is nuclei and stratum corneum, uh, they are alternating with the normal stratum corneum. These are features which are in favor of pityriasis rubra pilaris. So I suppose some of you must have guessed it. Then there are other disorders in which you are able to see lesions clinically, but histopath is generally very disappointing. You don't get specific reports. It doesn't help many a times. So pityriasis lichenoides chronica is one such situation where you'll have some sprinkling of lymphocytes in the papillary dermis. Some of them may be entering the epidermis, and then some have a non-specific perivascular inflammation. So that amount of aggregate and this sort of a pattern is very non-specific. It can be seen in anything. It can be seen in PMLA, drug reactions, any edema, any spongiotic dermatitis also. But what you have to see closely is some of these basic findings, like if you have some necrotic keratinocytes which are going higher up in epidermis, then you have exocytosis, basal cell vacuolization, and that very methodical way of seeing slides, then you might notice then there is lymphocytic vasculitis. So vasculitis primarily is neutrophilic, the classic vasculitis that we know of, but lymphocytic infiltrate around the vessel and slightly damaging it is also called vasculitis. So lymphocytic vasculitis is not so common tissue reaction. Then pityriasis rosea again. So what I am trying to convey through these slides is that if you are sure clinically, then it is better not to go with the histopathology of these slides. So don't do biopsy in such cases when you are sure clinically. So it may not help you. And even when you are unsure, then also it may not help you. So you must understand and you must be able to correlate clinically in these slides. So again, rosea has non-specific spongiosis, some lymphocytic exocytosis, some necrotic keratinocytes. So it's just like a repetition of the previous slide, almost in terms of fine findings. When you come to mycosis fungoides, this is important because you have to understand and explain the prognosis since it is early stage of cutaneous T-cell lymphoma. But even then, if you are not able to reach a diagnosis of mycosis fungoides, follow-up can reveal your diagnosis. And follow-up can reveal you your prognosis also. Because oftentimes in early or patch stage mycosis fungoides, prognosis is absolutely excellent. So you don't need to worry and you don't need to counsel too much also, because if you counsel too much, then the patient gets worried. So then again, you may have minimal interface changes, but there are finer points like you have lymphocytes entering epidermis, which are slightly bigger than the dermal lymphocytes. And there is absence of spongiosis or very minimal spongiosis, minimal edema. So haloing of lymphocytes may be there, but there is not much edema in rest of the epidermis. And the collagen may be thin and wiry. So these are some of the finer points. Sometimes I have just included this as a variation because pemphigus is something which we don't confuse. Okay, so we don't confuse it clinically, and oftentimes we don't confuse it histologically. But if you do a biopsy in very early stages of, let's say, foliaceous, you may not see that acantholysis. Acantholysis will be missed because there is very minimal acantholysis or maybe even absent in very early phases. In early cases, whatever you may end up seeing is just sort of a spongiosis, some infiltration of eosinophils entering the epidermis. So eosinophilic spongiosis may be there, some vacuolization may be there, and some clefting may be there, but without acantholysis. So some of these findings can be taken into consideration when the histopathologist is trying to reach a diagnosis, and it may help when they correlate this with the clinical findings. Now, coming to predominantly dermal disorders, which we can label as subtle or invisible dermatosis. So, more often than not, you have pigmentary disorders. So, pigmentary disorders are common in Indian population. All of us are quite irritated with them as clinicians because we are not able to offer good treatment to them. The treatments, whatever there are, lead to partial remission, incomplete that is. And more often than not, when you stop the management or you try to taper off the topical or oral medications, they will tend to come back. So it's very poor prognosis, I would say. Not in every case. Some patients do well on treatment, and despite stopping treatment, they will continue to do it. So again, one of my advices for such cases is, like, if you come across cases of melasma or freckles, lentigens, caffeole macules, or acanthosis nigricans for that matter. So in many of these cases, you may not get the exact histopathology finding. Melasma and all of these pigmentary disorders have a very non-specific histopathology. So please don't biopsy these lesions unless you are thinking of something like melanoma, which you are getting confused with melasma, which is very unlikely. You won't ever have this confusion, I think. But still, if you have, then you can go ahead and do biopsy. Otherwise, do don't biopsy these lesions. So yeah, some of the interesting cases that have been published in literature. So LE, so we all come across various spectrums of lupus erythematosus in our day-to-day practice, and what we often see is DL. DL is the commonest, followed by, I suppose, acute LE and subacute cutaneous LE. But there are some variations of LE also, like this series was published sometime back in IGDVL, and I think it's a recurring thought. It has been published in American Journal of Dermatopathology also, and subsequent reports have come up. It is a very less well-defined entity. There have been confusion whether actually it was LE or not. So it is like if you see a pigmentary lesion on the face, on the photo-exposed area, and there is no preceding history of LE, but you have a high titer ANA, then you can think of macular LE. So it is good to know in terms of prognosis, because macular LE, I think, tends to improve in a better way than other pigmentary disorders like melasma, because LE will not tend to come back if your photoprotection and other management is fine. And it is just like a post-inflammatory hyperpigmentation, you can say. But still, in histopathology, you have findings suggestive of LE, like you have a mild interface dermatitis sometimes, in addition to pigment incontinence. And whatever is the basic finding that by which we define LE is superficial and deep lymphocytic infiltrate. So that amount of infiltrate you can find sometimes in macular pigmented LE also. So then you are sure that it is a pigmented variant of LE. Otherwise, it can look just like melasma, because oftentimes it will involve your malar eminences, malar eminences of forehead. So it becomes like a thought at the back of your mind. So whenever you have this clinical, like, suspicion of photosensitivity with such pigmentation, then you can work up for LE, basically. Then moving on to leprosy patients. Leprosy patients, of course, there are much less leprosy patients in the state of Rajasthan. I suppose more are there in the endemic areas of eastern part of the country. But whenever we see leprosy, then it has become a challenge over a period of time as compared to what we used to see 10, 15 years back. So now we are getting more and more challenging cases of leprosy, maybe more multibacillary leprosy, at least in my experience, which is very limited in terms of leprosy, at least in Jodhpur. In Delhi, we used to see a lot of leprosy. So what we come across with is multivacillated leprosy, or atypical presentations of leprosy, or ulcerated forms of leprosy, or just pigmentation. So this was one case which was actually detected just on skin biopsy. So patient had sensory loss, and there was no other finding, no skin lesion, and we just happened to do skin biopsy. And historically also, I think, I don't know what was found. Patient was not very confident about any previous treatment history. But when we looked at the histopathology, there were some foamy histiocytes, very cheeky. We were not able to see them very clearly. Very few foamy histiocytes, which were laden with this sort of a brown pigment. I apologize. I think because of the size of the image, the pigment is not seen. But there is slight brown pigmentation in the entire dermis, but more so in the foamy histiocytes. So this was an indicator that this patient has taken clofazimine before and probably is partially treated as of now, because his sensory loss was progressive and some amount of infiltration was about to come up but was not really there for us to appreciate. So then there was another interesting case series on silver poisoning. Basically, people who are fond of taking silver elaichis, silver coated elaichis, and silver coated tobacco and other stuff, betel nuts. So chronic exposure to these, number one, and number two, chronic exposure to some of the silver containing indigenous medications, which may be Ayurvedic or from other branches of indigenous medications. So chronic exposure can, if you must be aware that chronic exposure to some of the arsenic containing medications of indigenous origin can cause arsenic toxicity. Similarly, silver toxicity can cause argyria. So what you get is basically bluish, silvery appearance or shiny appearance over the face, and it is known to get deposited well in the eccrine ducts. So this is a polarizing photomicrograph wherein you can see the shiny silver particles inside the eccrine ducts, which may not be clearly seen, which will be seen only as a fine bluish dispersion on HND. Similar fine blue particles can be seen after minocycline intake also, but not really restricted to eccrine glands. They can be around follicles or some other places also. So pigmented purpuric dermatosis is again a pigmented disorder. So basically, you do biopsy only when you have other very aggressive thoughts. Let's say you are thinking of a lymphoma, or you are thinking of Kaposi sarcoma, or some other sinister disorder. Then you will end up biopsying them. Otherwise, PPD is something which we commonly see in our OPDs. Patients who are in occupations who have to stand all throughout the day, like teachers or policemen or standing jobs in other professions also, maybe surgeons, yes. So you can see in those situations even without varicose veins. So when you end up biopsying them, you have some mild infiltrate in the perivascular location. If it is advanced, then you will see more and more infiltrate in the papillary dermis also. But mind you, without damaging the basal layer of the epidermis. So there is an acronym which is mentioned in textbooks, especially Whedon mentions this, which goes by the name of LUMP. So LUMP is acronymized version of papillary dermal infiltrates in dermatology. So what you have is L starts with lichen planus and Langerhans histiocytosis. U for urticaria pigmentosa, so mastocytosis can also have. Then M for mycosis fungoides and P for PPD, pigmented purpuric dermatosis. So they can look similar, but obviously in PPD you will have a lot of hemosiderin, dilated vascular channels. So hemosiderin can be seen in HND also as a golden brown pigment, or it can be seen in iron stains like pearl stain, for example, as a red colored deposit in the dermis, especially around the perivascular location. Then amyloidosis can be very tricky sometimes. It has fooled us many times. So what you will see is mild amount of pigmentation. We Indians are very adept at diagnosing amyloidosis because we know that ripple pattern commonly seen in middle-aged females may or may not be on sun exposed sites, extensor pattern predominant, and history of some oil or hair oil use. So all those things make us think towards macular amyloidosis. Lichen amyloidosis is not a difficult thing to diagnose, but macular oftentimes becomes, because if it doesn't have the rippled pattern that we see over the nape of neck or the upper chest or extensor of arms, then we are in trouble. So we end up biopsying them, and then in histopathology in HND also, the amount of amyloid may be so less that you may not be able to make a diagnosis of amyloidosis. It is only on special stain that you may be able to make. But mind you, if you are not able to see something in HND, it is less likely you will see in special stain also, unless you have the right bent of mind and clinical impression. Because if you have the wrong impression, then you will do some stains which are not even relevant. Okay? So then you won't be able to see anything. So the finer findings that can point you towards macular amyloidosis or amyloidosis is some of the clefts that may be seen in papillary dermis. Some melanocytes may be mixed in with the pinkish material. Then you may note that this can be macular amyloidosis. There are eosinophilic deposits, but in early it is very easy to miss. Then you can move on to mastocytosis. Now, mast cell is something which creates a headache for the dermatologist, because you biopsy something Your pathologist ends up reporting there are more number of mast cells, and then you are in trouble. You are in immense confusion then how to explain mast cells. Because mast cells are actually, you have to understand they are the normal population in the dermis. Only the number, when it is increased, then it becomes abnormal. But what number is abnormal is not clearly defined. Okay, so from patient to patient, if you biopsy a normal, absolutely non-atopic individual, nowadays hardly anybody is non-atopic, everybody is atopic. So if you biopsy a non-atopic individual who hasn't had any pruritus throughout life, then you might have a biopsy wherein very few are absent mast cells. But if you do biopsy from all individuals across all age spectrums, you may find subtle variation in the number of mast cells. So what number of mast cells is abnormal and what should make you think that it is pathological, it is very difficult to judge. So basically you have to go by the location of mast cells, that is number one, whether they are degranulating or not, number two, and then associated findings which are there in your clinical image or in the patient. So based on that, you reach a diagnosis of mastocytosis. Otherwise, atopics will show mast cells, leprosy patients will show mast cells, insect bite hypersensitivity will show mast cells. So anybody can show mast cells. So you'll have this perivascular papillary dermal infiltrate of mast cells. Then you are more sure that urticaria pigmentosa. Okay, I am. I have to think in that direction. Then special strains, of course, can uh, conclude because they are very specific to mast cells. And then we move on from pigmentary disorders to hypomelanizing disorders. So vitiligo is one such disease. I totally understand that most of us don't biopsy vitiligo. Why would we biopsy vitiligo? Diagnosis is certain. But sometimes there is confusion between vitiligo and other demelanizing disorders like maybe end stage of DLE, maybe other disorders like nevus depigmentosus, segmental vitiligo versus nevus depigmentosus. So many things are there. Sometimes it may be confused with genetic disorder like piebaldism. So in those scenarios, virtually biopsies, again, I would say it is useless. Okay, so what you will end up seeing is maybe reduced number of um, melanocytes in the basal layer, reduced basal cell melanization in hematoxylin and eosin stains, okay, or absent melanocytes. But to your utter dismay, we have seen biopsy slides from vitiligo. In a previous study, also in our departmental thesis, also I have seen the slides. To your utter dismay, even if you have vitiligo, the melanocytes may not be completely absent. So then you will be again in doubt whether it is vitiligo or not. So in those cases, I would say obviously you will go by what your clinical information says. But in early vitiligo, if you end up biopsying, you can see specific changes because the CD8 cytotoxic T lymphocytes damage the melanocytes. So you will see a lymphocytic infiltrate at the basal layer. Okay, and again, this will be more at the active edge. If you have a progressive vitiligo, or if you have a trichrome pattern, or if you have a vitiligo with like punctate depigmentation all around it. Okay, so in those cases, confetti-like depigmentation that is called. So in those cases, activity is more. In those cases, unstable vitiligo changes will be seen in dermoscopy. So in those cases only, histopath changes will also be seen. So otherwise, they are not very common. It will look like a normal epidermis, one or two scattered melanophages, and then that's it. No dermal findings. So you will be like looking at a blank slide, totally invisible, unless you see the biopsy form. Okay, they are thinking of it. Okay, and there are series from India and some of our own cases. I have seen a case of blue vitiligo. If some of you may have seen, then if some of you may have seen, I will be happy to learn from you also. I saw one case of blue vitiligo. It had this bluish hue, and on histopathology we saw lots of colloid bodies like grapes, red grapes. Lots of colloid bodies, lot of pigment incontinence. Probably it was a lichenoid process which led to pigmentation, and on top of that, vitiligo was there. So the intermingling of two colors led to a blue color. But the inflammation or interface dermatitis in vitiligo is not uncommon. This particular case series published in International Journal of Dermatology is also from one of our colleagues, Dr. Sasi from Vizag. So he saw a lot of infiltrate at the interface in the periacrine location, perifollicular location. So it can be there in early cases of vitiligo. Then obviously mycosis fungoides, it is a rare disease, but it can present with both hyperpigmented lesions and hypopigmented lesions. So hypopigmented mycosis fungoides can create confusion sometimes with pityriasis alba, with the early phases of BL or BT leprosy, where only hypopigmentation is there. But you have to look at the features which I had already discussed. You have haloid lymphocytes in epidermis which are bigger than the dermal lymphocytes, grouping of lymphocytes which is called porphyria microabscess, lack of spongiosis or minimal spongiosis. So those are early features. And then you have other tropisms like folliculotropism around follicles, syringotropism around the eccrine gland. So those features can point you in direction of mycosis. Then morphia again is something which is histologically inapparent. If you look at the slide, dermis is free from anything. Epidermis is again free from any uh, specific finding. So what you have to do is look closely at higher power. Sometimes at low power you might miss. At higher power you will clearly see there is sclerosis. So sclerosis means bland eosinophilic hyaline appearance of collagen and reduced number of nuclei or reduced number of fibroblasts. So more of ground substance, less of nuclei. So this is called sclerosis. It is different from fibrosis because in fibrosis you will see the nuclei also. And in morphia and lichen sclerosis, this is the difference. Lichen sclerosis is something which starts from papillary dermis and stays there or slightly down. And morphia is something which starts from the deeper dermis and comes up. So therein lies the difference. And in early phases in both, you will see lymphocytic infiltrate. So in morphia, you will see lymphocytic infiltrate at the dermal subcutaneous junction in early phases. And in lichen sclerosis, you will see at the dermo-epidermal junction. So it might just look like lichen planus in early phases. So it's interesting to note that so many disorders can mimic lichen planus, at least histologically. So this is something that I already discussed. And then you come to other soft tissue disorders which will be invisible no matter what. So some of these disorders are invisible clinically also, like pseudoxanthoma elasticum. You may just notice some yellowish hue or some increased skin folds in the neck or in the axilla without any other contributing systemic symptoms. And then if you biopsy, again, hematoxylin eosin stain will not show anything. So you will have to think in that direction. And if you do the right stains, like in this case, you do Verhoeven Van Giessen, which is an elastic tissue stain or an Orsin stain you can do for elastic tissue, then you will see the clumped up elastic fibers which are fragmented. Okay. But this again will be there as a band, almost like a band or clumping will be there in the mid dermis, in the perifollicular location primarily. So this way you can reach a diagnosis with the help of special stains. Then mucinosis is again one tricky chap because in histopathology, so these are like subtle disorders. Okay, in hematoxylin eosin, you may not notice mucin at all. As soon as we know that there is a diagnosis of mucinosis, we have that suspicion clinically. But in histology, don't expect pools and pools of mucin. Okay, you will get very stringy mucin like cobweb, like spider webs in between the collagen bundles. So sprinkling of mucin here and there between the collagen bundles, leading to sclerosis or thickening of the dermis, then leading to this fibroplasia or fibrosis. These are some of the features which can lead to diagnosis of scleromyxedema. And sclerodema will not even have fibrosis. So it will just have these cobweb-like appearing mucin deposits, but it will have a square-shaped biopsy. So all of these fibrosing disorders or mucin disorders can have square-shaped biopsy because of the inherent fibrotic component. So it is again not specific for mucinosis. Even morphia can have square-shaped biopsies. Okay, so again you have another sort of variant of mycosis fungoides. So this is follicular mucinosis. Clinically, it may have just a small amount of alopecia or maybe just faint erythema. That's it, and nothing else. But on histology, if it is well developed, you will see mucin inside the hair follicular epithelium. Otherwise, in early stages, again, no finding. Perifollicular lymphocytic infiltrate, very non-specific. And urticaria, we oftentimes do not do histopathology. So you have perivascular eosinophilic infiltrate. So generally, we do not do urticaria. We do not do biopsy for urticaria. We should do biopsy only if you think that it can be bullous pemphigoid urticated form, or it can be the urticarial vasculitis as a group of disorder among vasculitis. So otherwise, no need to do biopsies. And then sometimes biopsies again may just show sort of a busy dermis in the low power. In higher power, you will end up seeing that okay, there are fibrohistiocytes in between the collagen bundles. There is no specific granuloma in this specific variant of granuloma annulare, but there are just interstitial histiocytes. Okay, so there are few other subtle dermal dermatosis with which we cannot diagnose on basis of histopathology. So atrophodermas will not show much, just thinned out dermis and nothing else. Lipoatrophy obviously will not show much if you do a superficial biopsy because the atrophy of fat will be there, which anyways cannot be made out in histopath. That is a absolute manner of atrophy which we see clinically or maybe radiologically. So some of the infections can also be very challenging to diagnose. So dermatophytosis, we don't do biopsy, but sometimes it gets picked up as an incidental finding when we do biopsy for something else. So in those cases, it can be picked up. But if you are very sure and your KOH is negative, still you want a documentation of tinea, then you can do a biopsy. And you may not find organisms very clearly in HND, but then you have to go for PAS stain. Sandwich sign is a sign when you have very fine filaments, hyphae, in between the various layers of stratum corneum. So that is called sandwich sign. Sometimes they may enter the hair follicle. So that can happen in tinea capitis. So not many findings. Some neutrophil or eosinophil infiltrate may be there in the epidermis producing spongiosis. So that can be there. Okay, and special stains will reveal the organism to you. Similarly, pityriasis urticaler is something for which we don't do biopsy. We end up doing biopsy sometimes when we are confusing it with some maybe let's say hypopigmenting disorder, or if it is a pigmented variant of PV, then hyperpigmented disorder. So then you will see just spores in the stratum corneum. Especially commonly, I have seen that in uppermost layers of stratum corneum and wherever you have follicular plugs. So that can be there because Pityrosporum folliculitis is also a known entity, even though we are not able to prove it more often than not. Then you have some deep fungal infections, which may just show normal looking skin with some areas of necrosis. So in those cases, you have to be very careful and look for fungus only in the areas of necrosis, or maybe some histiocytes if they are there. Otherwise, HND may be unremarkable. And if there is mixed infiltrate of neutrophils and eosinophils, that is again a place to look for them. But generally, they are seen only where there are necrosis or histiocytes. So scabies is something which again may be an incidental finding on biopsy. We don't do biopsy scabies. But if you end up doing it, then some of the features which are there, which can confuse you, because eosinophilic spongiosis is so non-specific. It can be there in contact dermatitis. It can be there in atopic dermatitis. It can be there in insect bites. So it can confuse you. So histologically, these are confusing terms. So indeterminate leprosy is again is confusing a disorder. Okay, so what you will end up seeing is just perineural slight lymphocytic infiltrate. Okay, so this sort of an infiltrate is considered very non-specific unless you are able to document actual AFB in special stain. So we have to be mindful and obviously we have to correlate clinical. So these are some of our cases. So going to case number one, since I was told that this 1 hour lecture. So last 10-15 minutes we'll spend on our cases. So we got a 36-year-old female. She had thickening of skin over the chest for past 3 months, which was progressive. She had no other systemic symptoms. and multiple punch biopsy we had to do because we thought it is extensive lesion. So we can take from multiple sites because there was slight variation in morphology. So chest and axilla we did a biopsy from, and I'll show you the picture, clinical image. So I understand cannot answer, but maybe you can type your responses and I can maybe see later on. So you can see a hard bound down skin, slight amount of erythema and pigmentation over the chest area, pre-sternal area, even the area over the epigastric fold and hypochondriac area. So all those were showing slight erythema, pigmentation. And when we tested, then it was bound down. So we thought of disorders like morphia or let's say extensive morphia, generalized morphia. All those were the thoughts that were coming to our mind. And when we looked at histopathology, it is absolutely non-specific. Okay. So what we were expecting clinically is not there histologically. So these are some of the subtle or invisible dermatosis histologically. Okay. What you are able to see is just fibrosis and nothing pretty. That's all, nothing else. So when we looked at this slide, we were unhappy. So we asked our histopathologist to do more and more sections and deeper cuts. So eventually, when we did deeper cuts, some findings started to show. But this was something which was not very specific for us in dermatology. So what you can see here in the upper photograph, you have some dark staining nuclei. Okay, big size dark staining nuclei which are appearing or infiltrating between the collagen bundles and perivascular location. And if you see the lower image, then they have this pattern. They are present in shapes of strands linearly in between collagen bundles. So what is known as the Indian filing pattern. Okay. And you have this aggregate of some sort of squamoid or atypical cells, which is actually present inside the vessel wall. Okay. So it is present in the lumen. So it's almost sort of a emboli. So I think diagnosis may be clear to some of you now. So we basically reached a diagnosis of inflammatory carcinoma breast, which had metastasized to skin, leading to sclerodermoid morphology. So this was a difficult case, but we were unhappy for the patient in a way that this was stage 4 directly whenever you have skin involvement. But we were happy that we were able to diagnose it before our surgeons based on our clinical impression and slide going. So this is something which comes in handy. So now second case was a 48-year-old man. He had hyperpigmented indurated plaque on right side of the back for last 8 years. There were some other findings like flexion deformity of the left hand, wrist and elbow. So we were thinking maybe this is morphia, okay, and maybe he had, because he had met with trauma also, he had met with accident. So this is just a flexion deformity because of accident. But when we looked at the patient in the slide, basically, so we looked at the slide and you can see there's nothing to suggest anything. You have infiltrate, lymphocytic infiltrate in the upper dermis, in the perivascular location, and interstitium in between collagen bundle. And then you have just plain dermal collagen, just bland collagen. No activity, no sclerosis per se. Actually, these images are not very clear, but there was not much sclerosis here. And even if you expect in a sclerosing disorder like morphia, you will expect inflammation to be deeper, deep situated, but it was superficial. So without seeing the patient, this is our impression, we are nowhere. But when you correlate with the clinical picture, you have a wound, a non-healing wound because of flexion deformity on the dorsum of hand, and you have a pigmented lesion over the back and at that time he was not diagnosed, he was not seen by some physician outside, and it led to a burnt out morphia. So when you see a burnt out morphia, you don't see anything, you just see pigmentation, there is no binding down. So at that time also it could not be diagnosed, but over the years he has run from pillar to post to several institutes, and he has been diagnosed as pansclerotic morphia because of full thickness fibrosis. So sometimes histopathology again can be invisible. So we were unhappy for the patient because of the poor prognosis. So third case again was very non-specific. I am still confused about this lady. She was having this generalized scaling, some mild erythema and pruritus for last 30-35 years, and some amount of poikiloderma was present. Not much of atrophy, but telangiectasias, pigmentation, slight atrophy, and it used to worsen in winters. So we were not very sure. I was thinking of erythroderma, maybe psoriasis, maybe ichthyosis. We were not sure. But I will show you a finding. So clinically, you can see she has slight hyperpigmentation, some increased skin markings, okay, and very fine scaling, which is not even apparent in these images because they are at a distance and small size. So when you look at histopathology, I will give you the clue here. If you see spongiosis, again it is non-specific. If you see papillary dermal perivascular lymphocytic infiltrate, again non-specific. But if you see the stratum corneum, so it is not the basket wave type of stratum corneum. The stratum corneum is compact. So as soon as you see compact stratum corneum, and granular layer is very thin and focally absent in this. So we reach the diagnosis of a ichthyosiform disorder. But still now, we have not been able to slot her into one condition. So we are unhappy regarding that. But I have been following this lady for last 3-4 years, and she has not shown any other change. She is well controlled on things like emollient. Sometimes we have to give methotrexate. So she is possibly not something sinister like mycosis fungoides and not even like eczema. She's not symptomatic. So we have kept it as ichthyosiform disorder only. So again, biopsy was conclusive, but in a very fine way, very subtle finding. So this was an 80-year-old man. He had a scaly erythematous plaque on legs for last 6 years, and for 6 years they were plain top, scaly erythematous plaques. But for last 1 month only, they became verrucous. So he had lot of verrucous plaques on both the feet. Clinically, if you see, this is a very aggressive picture. You might worry for the patient that, oh God, what is going on with this patient? So he has sort of a verrucous appearance. Okay, rough surface, hyperpigmented, some black dots also. Okay, reduced scaling on those areas, more scaling on the surrounding plaques. So this was the picture over both the legs, and this is a picture on both the knees also. I have not put the photograph for that. So when we looked at the slide, it was looking like classic psoriasis. His history was also like psoriasis, except for the last 1 month. So this was showing these Monroe's microabscesses, subcorneal neutrophil deposit, neutrophils in the stratum corneum, then spongiotic pustules of Fogoch were there, suprapapillary thinning, all classic findings. Okay, so nothing suggestive of those verrucous plaques. So we were again in a dilemma. So we asked our pathologists to do deeper cuts, more step sections, and maybe cut from newer biopsy sites. Okay. So when they did a cut of the paraffin blocks, further and deeper cuts, then the picture emerged. Okay. So what you can see here is massive acanthosis, and there is no classic reti ridge pattern of the epidermis. So the epidermis has reti ridges which are fusing with each other, which are anastomosing with each other. And if you go deep down in the dermis, then you have lots of eccrine ducts, more in number than what you usually expect. So this was basically a reactive condition. It is known, it is published in literature. Over a plaque of long-standing, untreated or poorly treated psoriasis, uncontrolled psoriasis, you can have a reactive equine syringofibroadenoma. Okay, only unusual thing was that they were multiple in number in our case. So syringofibroadenomatosis. But it is a reactive condition. If you treat psoriasis well, it will disappear on its own. So this was case 5. Again, an elderly gentleman, slowly enlarging plaque over left cheek and periorbital area for last 8 years. He had this aggravation since 2 months and ulceration at the angle of eye. So when we saw this case, the eye deformity was very apparent. There was some eyelid damage also. So actually, we were thinking there were variable thoughts. We were thinking of infective disorders like lupus vulgaris, cutaneous TB, or maybe a fibrosing disorder like morphia, which has destroyed this, or maybe DLE, which has eaten away because this is showing some amount of hypopigmentation also in center and scarring. So all those were the thoughts going through our head, and maybe malignancy also. So when we looked at the biopsy slides, it was showing lots and lots of fibrosis, and superficial dermis was showing solar elastosis, which is a change due to sun damage. So they were quite non-specific. So we again asked our pathologist to do deeper sections, and then came our finding, what we were trying to look for, which was again sort of a bouncer in a way. So you have a lot of fibrosis, then you have these strands and nests of cells. Okay, basaloid cells. Basaloid as in bluish staining nuclei, tightly compact aggregates, which are of various shapes and sizes, strands and small nests, going between the fibrosed collagen. So this was basically a rare variant of basal cell carcinoma, which is called morphea form. Morphea-like pattern is there of immense fibrosis. In between that you have BCC nests. Okay. So one of the last cases, we had this lady with ovarian cancer who was a survivor, and she was having a relapse also. So post surgery, she was on chemo. So whenever a cancer patient comes to you with a skin lesion, you always try to think whether this is also related to cancer or not. So initially, when we saw that multiple ringed plaque on the right hand, along with few itchy papules, I thought maybe this is paraneoplastic. But definitely, I was overthinking, as you will see in subsequent images. So we always try to correlate with whatever we have. So if a patient has cancer, maybe even skin has cancer manifestation. So this was this multiple erythematous plaques were there, which were annular. So in a way, you sometimes try to see what you have never seen. So sort of a erythema gyratum repens. I saw a ring within a ring, another ring within a ring, and maybe even three rings some other place. So wishful thinking actually, because of the fact that we have not seen such a case of erythema gyratum repens. But when we did biopsy, then nothing. Okay, so considering that we had done biopsy, and after that only we did something else. So fairly non-specific perivascular infiltrate, mild spongiosis. Okay, nothing much to report about. But in further subsections, there was compact hyperkeratosis at some places. There were neutrophils in the epidermis, exocytosis, spongiosis. So that led to a fine thinking that maybe some parasite or maybe some fungus is there. So after, laughingly enough, I am considering and conceding my mistake here. Laughingly enough, after biopsy we did KVH, and KVH was positive. So this was a funny case for us. So it was basically not so apparent again histologically, but we didn't need histopath for this. So please be mindful that whenever we see cancer patient, don't read too much between the lines and go into cancer altogether. So this was our age-old friend Tina. So we were saved by KOH in this case. So this is my last case. This is a 26-year-old man, asymptomatic, non-progressive, brown-colored, irregular pigmentation over palm of left hand for last 10 years. Okay. And this was one of the index cases, but over the years I have seen some of these cases as a repetition. So I had staggered these cases, kept these cases to find if there was something interesting and relating between them. So we had thought of, see, you have brownish, greenish pigmentation over the palm. So what you can think of sometimes is, whether it is a nevus, Becker's nevus. It is not common in the palm, but okay, maybe it is. Whether it is a lentiginous or capiole macule, okay, or whether it is a vascular malformation. If it is too green, you can think of a venous malformation. Okay, this was the index case, which is there on the left side, and on the right side we saw similar case. It's very similar. You can see that predominant involvement is on the palmar aspect of the fingers, not on the palm per se. There is only slight extension onto the palm, and it's showing some sort of variegation. There is variation in the degree of brownness, the degree of greenness to this lesion, this patch or this macule. So we did histopathology. Again, we were astounded. We didn't see anything. Not even melanophages were there in this biopsy. So from an initial point of view, we looked at 2x, 4x. We were not able to find much. Okay. So as you can see, this is a biopsy from the palm. Lot of acanthosis, lot of hyperkeratosis. Uh, Fairly minimal amount of this sort of pigment is there here and there at one or two places, nothing else. Okay. But then when we started doing the step cuts and deeper sections, then some sort of a pattern emerged. Okay, in both these cases. So again, a palm biopsy which has been sectioned. So you see perivascular brown color. So you have a pigment in the perivascular location, and it's not the normal way melanophages are there. Melanophages are like groups of brown pigment in terms of dots and globules, small circles. But they were sort of elongated. Okay, so you have perivascularly located elongated brown cells, elongated cells containing brown pigment. So they were actually melanocytes. We were surprised to know, and we were very interested in these cases because they were only present in perivascular location. And when we went for special stains, special stains were done, and it clearly showed the elongated cells. So these brown cells behave because melanocytes have these dendritic processes. Okay. So when melanocytes have these dendritic process, they will appear as elongated cells. So it proved that this was a case of dermal melanocytosis. So these were basically cases of extrafacial acquired dermal melanocytosis, and we have recently published them as a series of cases seen over last 5 years. So this was the interesting part. So this comes to the close of today's talk. So you can have clinically inapparent, you can have histologically inapparent, you can have difficult cases which are difficult to diagnose. So what I have tried to convey through this lecture, I hope, is that you have to look at the finer points on biopsy. And if you are not looking at the slides, then you have to look at the reports. You should request, you should talk to the pathologist again and again if you are not getting those findings. So these are the summary. This is a flow chart that I have made. We look from head to toe, epidermis, dermis, subcutaneous, from low power to high power. And when you are not seeing the specific finding, do not discard the minor finding because they can also take you to a diagnosis. Initially, you can rule out some technical error or biopsy error if you don't see finding, but you can do more and more step cuts. You can read your books, then see the slide, then talk to the pathologist. So it's like that. So eventually, it is something which lies on CPC. So I have renamed CPC as clinician pathologist communication rather than correlation. Communication is of paramount importance. So thank you very much, and I especially thank Mathur for this opportunity.
Thank you very much. Thanks a lot, Saurabh. It was indeed a very learning exercise and a lot many appreciations and these things in the chat box. Dr. Datta is there, and I would like to have his comment. My senior friend, Dr. R.N. Datta is here. So he will finish up, and Dr. Joshi is also there from Kuwait.
It is a fantastic presentation,
Satyesh
Dr.
from,
Mathur.
Thank you, sir.
Thanks to Saurabh. It is really good.
Thank you, sir.
We learned a lot.
thank you very much, sir.
Thank you, sir.
Saurabh, would you,
Thank you. So nice of you.
did you do the summary of that drug, or
Yes, sir. Actually, sir, I will concede that I took help of my junior resident, and I think he has done a good job. I will just, I think I'll just project that slide that
because
he has
nowadays
made.
there's a drug which DRDO has developed, and that is a
Yes, sir.
lot of publicity for the COVID patients, which reduces the oxygen consumption, oxygen requirement. So I said that you just review it. Yes, please show it if you can.
Yeah. Okay. Yeah, I'm just making it full screen, sir. Just give me a minute.
Sure. because I keep on doing on this
Yeah, yeah.
COVID.
Yes, sir. You are very well versed with all the systems, sir. You are the king of software using now, I
No, no.
suppose. The youngsters are not that well aware of. Is my screen visible now?
Oh yes.
Okay, so this is courtesy Shubham, who is our player one. So 2-deoxy D-glucose is a ion of glucose. So primarily it is a glucose molecule which has two hydroxyl groups replaced by hydrogen, and this avoids further glycolysis. So by this method, it has two properties. It has this ability to inhibit glycolysis. Therefore, it will affect those molecules which are rapidly multiplying. So let's say cancer cells. So this has been in vogue. This molecule is not something which has come out of thin air all of a sudden into the market and into the news. This has been used in laboratory especially for many years as a substitute, as a therapy for cancer. So they have tried it in so many things. It can be used as a diagnostic agent in its radio labeled form. Fluorine 18 can be combined. It can be. It has been studied in basically in vitro studies, and phase 1 and phase 2 studies are there as an adjuvant to chemotherapy and radiotherapy for solid tumors, and even in herpes simplex infection because of
Oh.
some sort of a antiviral property as it inhibits entry of virus into the cells. So when we look at the COVID pathogenesis, then entry is the most important step. They are dependent on binding of SARS-CoV-2 to cellular receptors, which is primarily ACE2. Secondly, after that, virus starts replicating, and virus nucleases are there and proteases are there. And after the entry, host cells is observed to undergo metabolic reprogramming to meet the demands of nutrients and energy for replication of virus. So therein lies the hypothesis that maybe 2-deoxyglucose may serve as a probable drug which will inhibit glycolysis as well as this transfer of energy to the virus, which it needs for replication. So COVID manifestations, we all know, a lot of things have been explained. A lot of immunology is there, which is published. A lot of immunology is still unexplained. This is the possible mechanism in COVID. So it can form salt bridges with amino acid residues, namely protease, CL-Pro, and viral spike glycoprotein. So it was observed that hydroxyl group formed a hydrogen bond with the proline amino acid, and thus it can neutralize the virus. And its derivatives can also do a similar work, basically forming a hydrogen bond. And binding of ligands and viral receptors thus basically is hindered in such scenarios. So these are the complex biochemistry diagrams that are here. So in simple manner, if we can explain, it can influence several pathways towards glucose. It can influence glycolysis, glycosylation, endoplasmic reticulum, phagocytosis, and competitively it will be taken up by the infected cells, which will lead to this molecule 2-deoxy D-glucose 6-phosphate by means of hexokinase enzyme. And this 2-DG6P cannot be further metabolized. Thus, it will hamper the bioenergetic process. So, it will hamper the ATP production basically, and it can lead to cell cycle arrest. But I suppose this is not specific to the virus, so it can lead to arrest of anything which is rapidly multiplying. So, the effects and side effects may be there, which we can correlate from this theory, and then ATP levels will be diminished and expression of P53 will be induced, which will lead to cell cycle arrest of the virus. So this way it can produce its effect. So entry will be inhibited, and then the required energy for viral replication will be blocked. So both the things, and this is the news item which came up. So 7th or 8th of May, DCGI approved this. So about the approval system, I can say this: in April they first found out. This is a branch of INMAS, INMAS, which is a nuclear medicine wing of DRDO in Delhi. So they have been conducting experiments, and with their collaboration in Hyderabad, they found that this molecule worked effectively and inhibited the growth of SARS-CoV-2. Based on these results, DCGI approved and permitted a phase 2 trial. This was a phase 1 in animal, phase 2 for human study in May 2020. From May to October, they did on 19 patients and they showed significant improvement. I think that data I was not able to trace anywhere in the literature. It is just appearing as a news item. So maybe I have to search more, or maybe it is really not there in public domain. Then when phase 2 was successful, then phase 2B was there in another number of hospitals, conducted in 110 patients. Then they came up with a very big difference. So I don't know whether this is a statistical difference or is it clinically relevant. So if you are able to give a difference of 2.5 days, does it really matter to patients or doctors? I'm not very sure. So based on this, it was encouraging nonetheless. So they conducted a bigger trial in a phase 3 trial on 220 patients from December to March. So they have compared with supplemental oxygen, and they found about 11% advantage and early relief from oxygen dependence. So similar trend was seen in in patients who were more than 65 years of age. So eventually in May beginning, DCGI has granted approval. So this is in infancy, not in infancy, but still its use is in infancy. We cannot be sure. It is available as an oral drug formulation in a sachet, like we have vitamin D sachets. It can be mixed and drank with water. Okay, and it will probably block. So what happens literally is that you have a molecule. Most often we have seen this in COVID, that we have a molecule which produces improvement in COVID, and then we start thinking about the mechanism. So it is the reverse order. Firstly, ideally, we should know the mechanism and then we should start doing the trials. Here, what happens is we are doing the trials and then retrospect, we are thinking that maybe this is a possible mechanism. So it is both ways. This is a molecule which I think has been in vogue and is being studied for cancer for many years, at least 1 to 2 decades. But still, it is unapproved. So you can understand that the mechanism, the efficacy is not really known as of now. And this was one of the different studies. So I came across this article which is combined approach of adjuvant 2-deoxy D-glucose with low dose radiation therapy to improve the cytokine storm in COVID-19. This is a published article. So there is evidence, okay, but how much evidence is good enough and how clinically relevant this is, we don't know. So yeah, thank you very much, sir.
All right. Thank you very much. Thanks a lot, Saurabh. It was indeed an very important information which we wanted to know. And thank you very much. And since there are not much questions, everything has been answered in the chat box also. Not much questions. People are flabbergasted with your presentation. Thank you very much. And good night, everyone.
Thank you, sir.